Hi, good morning, everyone. I don't have any slides, so and I just want to thank you, Dr. Kirsch, for having me here, and Rachel for inviting me. So I hope I don't get anyone in trouble, or I hope I don't get in trouble, because I'm going to speak off the, I'm going to keep it real about some of the things that, basically, a lot of the things that we talked about as far as implementing a new scheduling system, what are the requirements that we're going to need, things like that. From my perspective, being in a scheduling world and coming from a scheduling world, I'll kind of give you the, what's happening on the front line there. And so I guess the first one is how do we, what are the goals, what are we trying to do for key requirements? I just want to, scheduling, one of the key requirements for the scheduler is really if you can incorporate something that helps us do our job without errors, right? So, we get hired onto the VA. We really want to help out the veteran. They come to our front desk. They feel like we have all the answers, and it could be my first day on the job. So creating a scheduling system that is error-free, that's intuitive, is going to be really important so that we can improve the access of our vet to care, that they're getting the right care at the right time, the way that they want it. I think the second thing is really to stay veteran-centric. By providing online services or allowing the freedom for the veteran to choose what they want. And then also to improve provider productivity, so utilizing all of the time that they're there without overwhelming them. I think of a lot of the functionalities that are essential, and I probably could take 20 minutes just talking about that. But definitely we need to move from right now the VA has we call them grids or clinics. We need to move to a resource-based scheduling system, again, decrease errors. One of the sticking points, I think, with our scheduling system today is that it's not tamper-proof. It's not transparent. We have access that can be put in, so the schedules can be entered, and then the schedules can be removed, and we have no tracking system of who's doing what. So that's, I think, really essential when it comes to functionality, that we are able to track who removes and puts in access. Improving the provider and scheduler productivity is going to be good. So sometimes, as a scheduler, you can sit next to somebody and you feel like you're working all day long, and what's this other person doing, So it's like balancing that workload so that we can see that not only the provider is productive, but the scheduler is productive, I think is important. And then just improving the community care workflow. Making that all one system so that we can see, I may be hustling and trying to schedule a consult, but maybe they're getting community care, right? So they have duplicates in the system that we can't see. So having just one system for that community care so we can see the workflows throughout the hospital. Let's see. The integration between the scheduler and the patient request. Right now we go to different queues for that as well. So as if we can open up for veterans to schedule, seeing where those options are in one place. Right now we go to probably two different places to find out the request for veterans, or the veterans are requesting. We also experience delays in the phones. So if a veteran, I have a friend of mine, and this is completely transparent, who says on Friday that they called and they threw called the message center. I threw my back out. Can you see me today? Sure, we'll give you a call back. That person went to the ER on Saturday and was not called back, right? So the reality of our same-day services, that messaging between the patient and the scheduler, there was some kind of disconnect. What happened there, So really connecting those dots so that we can offer the same-day care services that our providers are ready to give. And then kind of the key requirements into phasing. I know that we're going right now through a really difficult time with the overlay system that we have with our scheduling. It's called VS GUI. It's an interface. And when I think about phasing in a new system, I think about, wow, we didn't really give VSGUI, when it overlays into our Vista source of truth system, unintentional bugs have been created as we've tried to go through different versions. So when I think of a new system and phasing it in and how would this work, could we create a test environment that everyone could use, fully operational test environment that a veteran could possibly access and that users could access, so that we work out those bugs ahead of time. I know that there's going to be probably new versions, and healthcare is ever changing, but at least we have a chance to work in an operational environment and include the veteran as well. Allow experts to give you feedback, make sure that there's stakeholder awareness. I think that more importantly, getting the word out about what we have and making folks aware all the way down to the front line and in between, the middle managers knowing what's coming before is very helpful. Having buy-in from all those key stakeholders is important. And that I think we learned a lot yesterday when we had our scenarios. So making sure that as we're learning and we're phasing these things in, we're getting things new, that it's all scenario based according to what our veterans' needs are. I think that sometimes we come in and there's the needs that we think that are a lot of the patients in the private sector would need, but just really catering those scenarios to our veterans would be very helpful when we think about phasing and training. And then also having like a communication line, maybe a help desk, so that when we roll it out that folks are all aware of who they can call or they have assistance. So that's kind of like the requirements, key requirements and phasing. And then I wanted to talk a little bit about the primary care challenges, some of the things like keeping the PCP, as Rachel talked about, and the continuity with that. Right now we have a system that when I go to schedule someone for primary care, if they're a new patient, I'm getting the information. We do have great reporting. It tells us, exactly how many patients, the percentage of your panel capacity, how long you have had the panel, if you're a new provider, or how long you've been established. And for the scheduling system now, it does. All the information is fed to the scheduler or to the call center. So you're relying on somebody to kind of tell you this provider is available and has this capacity, but doesn't really tell you what their availability is. So it'd be really nice if anyone at any time that's scheduling can see the assignment, can see who's open across all. When I think about it, I think about all locations. So providers can sometimes be at our community-based outpatient centers, and they can also be at the main hospital. So giving the veteran the choice of, hey, your provider's in 3 different locations, and this is what they offer at each location, would be very helpful. Some providers are offering primary care derm or pain or something like that, so it's really important to say, yes, your provider also does this and that. So to have that up front. Right now we don't have that. Sometimes it's delayed. We end up scheduling maybe new patients. If it's not updated, we could overschedule somebody whose panel is really closed, and we've given them new patients. Also, seeing a scheduling system that has how many new patients a day, if they're back to back, so we're not overwhelming the provider as well, is something that we can't see today, but it would be really nice to see. So we have providers that come back and say, hey, you gave me 3 new patients in a row. What are you doing? And all these things like that. And truly, we would have to run independent reports and then go back and look and see how did we schedule. So this, again, is creating a system where I can come to work, feel like I'm doing a great job, and I'm not going to have a tap on the shoulder saying you scheduled too many patients for me today. So definitely need something like that to reduce burnout and definitely help the morale between the staff. And also for primary care. There are quite a few queues. So we have a primary care provider can have maybe 4 to 6 different queues or clinic grids, and a lot of that's not readily available. So the system that we have right now kind of stacks everything side by side, and some of it may not be relevant because there's no scheduling capacity. So I think I mentioned yesterday about incorporating preferences for the veteran. So we know this veteran would like, virtual care is okay. Face-to-face is more preferred. Things like that. So that we're able to offer what the veteran would want. So if a primary care provider has 5 different clinics, we can see them all, and I can see, well, yes, I can definitely book you for VA Video Connect or something like that. So that's going to be, I believe, essential to make sure that we can see it all in one place and what we can book for. That was fast. Okay. Let me go through specialty. So for specialty care is really difficult because we have systems right now that we are measuring the access on consults. So when I think about, so for specialty care, a lot of the times the delays can be when, I think you folks call them referrals, but we call them consults. And when they come in without a lot of information sometimes. And so the decision making that the provider has to do up front can take maybe, I've heard providers take 3 hours out of their week just to review these referrals. And then as a scheduler, we get it and it has just some writing on it, or it just has, something inputted on there that says, next available or schedule at this, in this clinic. So in my mind, it seems like, there's the sending provider and the receiving provider. Those negotiations, those service agreements seem like so important to just handle up front. So having a decision tool within the consult so that the provider can click the boxes that are needed, get the tests that are required, so that there can be some direct scheduling happening, even maybe from primary care, that we allow folks to open it up, because constantly we're chasing veterans down to leave messages. Please call us back. Oh, why did I have a consult there? Then I'm trying to be a clinician and explain why you're coming in, for your new referral. So having the decision tree, or not decision tree, but like a decision tool or a built-in template that can allow for either myself as a scheduler to just schedule, or for an easier flow to triage, or even one step further, have the veteran be able to schedule their appointment. Also, what happens is those service agreements are often expiring, or they don't get reviewed often. So if there's any way you can put into your system a time and date stamp, so as you're putting in your consult referral, wow, this is 3 years old. Okay, I'm gonna do it, or something like that. Maybe there's some type of review that happens. I think that's a disconnect where we have a lot of paper shuffling around, and when was, I don't know, let me show it to you, so that there's just one system for that, and that's tracked. Let's see. The other thing I wanted to talk about was a lot of the coordination that happens between primary care and specialty care is a lot of the coordination can sometimes happen in the call center. So when I think about the call center, think about all of the things that we've done to kind of handicap folks. I feel like, when the veteran calls on the phone, we just want to give them what they want. We want to make sure that they're happy. And a lot of times we get restrictions so that the primary care can only schedule for primary care. Specialty can only schedule for specialty. And the person that schedules for dental, they have all the information in their head. So, so I'm looking forward to Cerner, as you folks are building in all these business rules to make it easier to schedule. So I think that's really some of the things that we're missing, some of the gaps. The other thing I can think about is in primary care, we have a disconnect with the provider continuity piece, where if I want to give you a real example. So my uncle went to his primary care provider. The primary care provider was constantly late, and so there was no problem. And then when my uncle got into the room, the phone rang. The primary care provider picked up the phone, took a brief call, hung up, and said, "Hey, I'm sorry about that." And then so my uncle felt completely disrespected of his time, so he walked out. And then he was supposed to be given a new provider. So he got the new provider, and then his provider called in sick. And so when his provider called in sick, they said, "Well, you just see a provider that's going to, sub for this provider, for your provider. Will you see a new provider?" "Sure, yeah, okay, yeah, I'm here already. Sure, I'll see a provider." So guess who opened the door and asked my uncle to sit down? So again, he walked out. And so if there's a way that we can, I think about this in women's health as well, when the male doctor or female doctor calls in sick, did we substitute that new provider for another female or male provider, which is something that maybe the veteran has expressed repeatedly that they want to see a certain type of provider. So if we could have some type of way that that's tracked, right now I can keep booking into the same provider or different provider, and so just up front, maybe a history. Even when I think about the traveling veteran, who's the provider today, who was the provider yesterday, and who does this provide? Who do they prefer to see, a female provider or male provider? So thank you very much for your time. I appreciate it. Look forward to any questions you have. Thank you.